Good evening, everyone. Welcome to the webinar series conducted by Dr. Ritu. Today, today the topic is pregnancy in the scar, diagnosis and management, the Tunisian experience. This series of webinar is a conversation between two icons. One icon is Dr. Ritu S. Santwani. Dr. Ritu ma'am is an obstetrician and gynecologist and an IVF specialist. Dr. Ritu is the founder and CEO of 360 Degrees Healthcare Studio. Dr. Ritu is an infertility specialist from NUHS Singapore. Dr. Ritu is a co-founder of MAAM and board member of SWWC. Today, the second icon who is the speaker of the show is Dr. Fathi. Dr. Fathi is an associate professor and obstetric and gynecologist. Dr. Fathi is from the Tunis Faculty of Medicine. I am handing over the session to Dr. Ritu ma'am.
Yeah, thank you, Chitra. And thank you, Shield Pharma, for providing the platform. A warm welcome to all of our dear friends who have joined all across the geography. So, friends, as we all know, by this series, the Icons and Conversation with Dr. Ritu. So, friends, here today we are having a very dear friend of mine, Dr. Fathi, is with us, and he is going to discuss with us a very important topic related to the pregnancy in the scar. We all get some or the other time the patients related to this. So, how to manage this? What are the practical problems? As already we are delayed for 10 minutes, the program just started going live on the YouTube. So now, without wasting any time, I'm handing over to Dr. Fathi. Once his talk is over, then we can discuss some questions. A warm welcome to you, Dr. Fathi. Warm welcome.
Thank you very much, Dr. Ritu. I am very happy to be with you in this nice meeting. I am an associate professor in gynecology and obstetric from Tunisia, from the Tunis Faculty of Medicine. Thank you again, and allow me to share my screen.
Yes, sure. You can share.
Thank you very much. You can see my screen? Dr. Ritu, you can
Yes,
see my screen now? Thank you very much.
I can see. Yes, I can see your screen. Only make it full screen.
Thank you very much.
Yeah.
And now it's okay?
Yes.
Thank you very much. So I am Dr. Mrahi Fathi. I am associate professor in the D department from the Maternal Center of Tunis from Tunisia, which is a third maternal center. It is a great honor to represent my country, Tunisia, and to be with you in the Icons in conversation with Dr. Ritu. And I will talk about cesarean scar pregnancy, diagnosis and management, and the Tunisian experience. So during this lecture, I will begin with definition and prevalence, then the risk factor of this condition, the sign and the symptoms, the classification of cesarean scar pregnancy, the treatment option of cesarean scar pregnancy, and finally the Tunisian experience. So I begin with the definition and the prevalence. Cesarean scar pregnancy is an increasing challenge worldwide. It is an ectopic pregnancy in which the fertilized egg is implanted in the muscle or fibrous tissue on the scar after a previous cesarean delivery. This condition will disrupt the integrity of the uterine wall and can lead to serious complication like hemorrhage and like uterine rupture. So, cesarean scar pregnancy occurs when a blastocyst implants in a microscopic or macroscopic tract on the uterine scar or in the niche or dehiscence left behind by an incision seat of the previous cesarean delivery. The primary cause of cesarean scar pregnancy is the damage to the endometrium and myometrium by a previous cesarean section.
Sorry to
The
disturb you, sir.
mechanism
Your slides are not
is
moving,
the
sir.
same
Yes, we will
after
tell him.
after
Dr. Fathi,
uterine.
your slides are not moving. Slides are not moving. Yes, yes, now we are able to see.
Excellent.
Yes.
So, cesarean scar pregnancy is an increasing challenge worldwide. It's an ectopic pregnancy. The fertilized egg is implanted in the muscle or fibrous tissue on the scar after a previous cesarean delivery, and it disrupts the integrity of the uterine wall. This condition can lead to serious complication like hemorrhage and uterine rupture. Cesarean scar pregnancy occurs when a blastocyst implant in a microscopic or macroscopic tract on the uterine scar or in the niche or dehiscence left behind an incision seat of the previous cesarean delivery. The primary cause of cesarean scar pregnancy is the damage to the endometrium and myometrium by a previous cesarean section. And the mechanism is the same after uterine surgery, like curettage, myomectomy, endometrial ablation, manual removal of placenta, or any intrauterine surgical manipulation, with one significant difference is that the latter causes are extremely rare. What is a niche or of a previous cesarean section? The niche or dehiscence is a distant continuity of the low anterior uterine wall seen after the healing process of a previous cesarean delivery. At times, a thick scar forms without leaving behind a defect. Other times, a usually triangle defect is visible either on an enhanced ultrasound or highlighted by a saline fusion ultrasound examination. So, cesarean scar pregnancy is characterized by first an empty uterus and cervical canal, like you see here. The uterus empty and the cervical canal is empty. Also, a gestational sac located in the anterior uterine wall, diminished myometrium between the sac and the bladder, and you can see here the bladder and the distance is diminished, and a discontinuity in the anterior wall of the uterus adjacent to the gestational sac. Regarding the prevalence of this condition, cesarean scar pregnancy was first described in 1978, and until 2001, only 19 cases were reported. But the incidence of this condition has gradually increased worldwide, and reported incidence estimates range from 1 in 1,800 to 1 in 2,226 of all pregnancy, and it was recently estimated that 1 in 531 women with a cesarean scar will have a cesarean scar pregnancy, and this condition accounts for 4% of ectopic pregnancies. Regarding the risk factor of this condition, the main risk factor of cesarean scar pregnancy is the prior cesarean section. And there is an increased risk with the number of cesarean sections. Other risk factors now are known as posterior fundal incision, which is a vertical incision on the back of the uterus, short inter-pregnancy interval, less than 80 months between pregnancy, in vitro fertilization, and the use of assisted reproductive technique. But the main risk factor of this condition is the prior cesarean section. What are the signs and symptoms of cesarean scar pregnancy? Symptoms can be subtle. Vaginal bleeding may be irregular or spotting, pelvic pain ranging from mild discomfort to severe cramping. Almost there is a positive pregnancy test, and symptoms and signs may mimic symptom of a threatened abortion. So early diagnosis of cesarean scar pregnancy is essential. It can prevent life-threatening complication, and the history and physical examination may evoke this serious condition. And transvaginal ultrasound is the key of the diagnosis of this condition. It may the visualization of an empty uterine cavity and cervical canal, and the identification of the gestational sac or a mass with vascularity at the cesarean scar. Regarding the classification of cesarean scar pregnancy, there are several classification of this condition, and these classification have evolved over time. They increasingly have a therapeutic implication, and there is no consensus classification. The first classification was described in 2000, and we classified the cesarean scar pregnancy in endogenic and exogenic type. In 2010, we classified this condition on intramural and non-intramural type. And then in 2017, Zarg and all have classified this condition on the risky and stable type. There are type 1, type 2, type 3. In 2017, also Kilian, Acton, and all classified the cesarean scar pregnancy on cesarean scar pregnancy in the niche and on the scar. In 2018, there is a new system, an ultrasound grading system, which allows to classify cesarean scar pregnancy in grade 1, grade 2, grade 3, and grade 4. And the most recent classification, which is the ISIOG reporting system, the it is the modified Delphi method, which was published in the ultrasound and the obstetric and gynecology. So, regarding the classification of risky and stable cesarean scar pregnancy, the risky cesarean pregnancy is classified type 1 when the thin myometrium less than 3 millimeter, and there are type 1A, 1B, 1C. 1A is the cesarean scar on lower uterine segment, type 1B cesarean scar in the upper uterine segment, and type 1C there are a giant protruding mass. The type 2 there are thick myometrium more than 3 millimeter, and type 3 the gestational sac deviation. And you can see here A, it is indicate a lower here a lower cesarean scar, while B indicate a higher cesarean scar, and the thickness of myometrial wall on A and B determines the type 1 or 2. And here you can see the C protruding mass, and D indicate a gestational sac located partly on the cesarean scar, is here, partly in the cesarean scar, which is called risky cesarean scar type 3. And concerning the ultrasound grading system, the grade 1 cesarean scar pregnancy is represented the depth of cesarean scar pregnancy embedded in less than one half thickness of the lower anterior corpus. The type 2 of cesarean scar pregnancy implied cesarean scar pregnancy occupied more than one half thickness of the lower anterior corpus, and you see here the gestational sac is on the myometrium, more than one half. In grade 3 cesarean scar pregnancy, the gestational sac bulged out the overlying myometrium, and this serosa you can see here is a grade 3 cesarean scar pregnancy. And the grade 4 cesarean scar pregnancy, the gestational sac become an amorphous tumor with a rich vascularity at the cesarean scar. And most recently, in 2022, the most recent classification is the modified Delphi methods, which is the use-yog reporting system. This classification uniform definition of cesarean scar pregnancy, and cesarean scar pregnancy can be used as a collective term in close contact with the niche, can occur only when a niche they're not in relation to a healed. A low implanted pregnancy is defined regarding to this classification system is defined as any pregnancy implanted near the knee or the scar without being in direct contact with it. And description of cesarean scar pregnancy depends on the intersection of two imaginary lines, the uterine cavity line and or the serosal line. And here this image show a pregnancy located near the cesarean niche or scar without being in direct contact with it, and it should be called a low implanted pregnancy. And you can see here the distance between the proximal border of the niche and the most distal border of the sac is the distance A and should be mentioned. And here you can see differentiation of cesarean scar in the second image, differentiation of cesarean scar pregnancy according to the position of the gestational sac in relation to two imaginary line, the uterine cavity line. This imaginary line at the transition of the endometrium and the myometrium, and the serosal line here, the imaginary line at the outer border of the myometrium. And this classification system, the residual myometrial thickness, RMT, and the adjacent myometrial thickness, AMT, in sagittal plane should be measured and reported in case of cesarean scar pregnancy. And measurement of the position of the gestational sac in relation to external orifice and in relation to the vesico-vaginal fold is not mandatory. For a suspected cesarean scar pregnancy, the evaluation of the vascular pattern and its relation to the niche, cervix, and adjacent uterine vascular anatomy using color Doppler is recommended. And here you can see the RMT and the IMT, the measurement of the residual myometrial thickness, and the AMT, the adjacent myometrial thickness in a sagittal plan in case of a niche or a gestational sac. Pulsed Doppler, 3D Doppler ultrasound, the Mrahi, are not mandatory for routine evaluation of cesarean scar pregnancy, and color Doppler examination is essential for the differential diagnosis of remnant of placental tissue and to search for the sign of enhanced myometrial vascularity, which is associated with a high risk of bleeding with both conservative and surgical management of cesarean scar pregnancy. And the diagnosis of cesarean scar pregnancy does not automatically means that the pregnancy need to be threatened. And according to this classification system, the modified Delphi method, the use reporting system, you can see here in the A and B images, donc cesarean scar with the largest part of gestational sac crossing the uterine cavity line. In C and D, on the second image, C and D, the cesarean scar pregnancy with the largest part of the gestational sac embedded in the myometrium and not crossing the uterine cavity line. And in E and F, the gestational, the cesarean scar pregnancy crossing the serosal line. There is the serosal line, and the cesarean scar pregnancy is crossing the serosal line. So it is some images from our department. Donc you can see here the uterus. This is the cesarean gestational sac. You can see here the uterine cavity line, the serosal line, the adjacent myometrial thickness, AMT, and there is no residual myometrial thickness here. There is no residual myometrial thickness. It is so also an image from our department. You can see here the uterine cavity line, the serosal line, the gestational sac, the residual myometrial thickness, and the adjacent myometrial thickness. And here the cesarean scar pregnancy with the largest part of the gestational sac embedded in the myometrium and not crossing the uterine cavity line. And here also some images from our department. And here also the cesarean scar pregnancy with the largest part of the gestational sac embedded in the myometrium and not crossing the uterine cavity line. And you can see the uterine cavity line, the serosal line, and the gestational sac, and the color Doppler, the vascularity of this gestational sac. And here you can see the 3D ultrasound can help us also in the diagnosis of cesarean scar pregnancy, and some images from our department. And here the vascularity of the gestational sac using the color Doppler, and it is richly vascularized. According to this paper, which is recently published on the European Journal of Obstetric and Gynecology about cesarean scar pregnancy, a systematic review, this paper concludes that enhanced contrast ultrasound holds promise for diagnosing and managing cesarean scar pregnancy by visualizing scar vascularization in real time. Thirdly, reducing severe complication risks. This review highlights contrast enhanced ultrasound as a transformative diagnosis tool for cesarean scar pregnancy management despite existing evidence limitation. Next, I will talk about treatment option of cesarean scar pregnancy, and I said that there is various management plan based on the gestational age, the embryo viability, the evidence of myometrial deficiency, the clinical symptom at the presentation, but there are no standardized guideline for the management of cesarean scar pregnancy, and most of management option for cesarean scar pregnancy are based on a single case or a case series. And this paper, which recently published in the American Journal of Obstetric and Gynecology in 2023, several conclude that several approaches have been studied for the management of cesarean scar ectopic pregnancy in women who opted for termination of pregnancy, including sharp curettage, dilatation and evacuation or curettage, excision of trophoblastic tissue, local or systemic administration of methotrexate, total or subtotal hysterectomy, and hysteroscopy. So there are several options for the treatment of cesarean scar pregnancy. First, donc, there are the expectant management, and the efficacy was low and the complication rate was high. And the second option is the systemic methotrexate, and with this option, additional treatment was necessary in 1/4 of case, and severe complications were seen in 13%. The third treatment option is local methotrexate, and the success rate was 64% with a complication rate of 4%. The fourth optional treatment option for cesarean scar pregnancy is the association of local and systemic methotrexate, and 1/4 of women required additional treatment, and the complication rate was 2%. The fifth treatment option is the resection of cesarean scar pregnancy through a transvaginal approach, and the complication rate was very low, approaching 1%. Other options like uterine dilatation and curettage, and a high complication rate of 21%, and additional treatment was needed in 50% of cases. There is also the hysteroscopy as a treatment option for cesarean scar pregnancy, and only 3% experienced a major complication with this technique, but 17% of women needed additional treatment. There are other treatment options like uterine artery embolization in combination with dilatation and curettage without methotrexate. This option is efficient in relation to additional treatment needed. Only 6% of women need additional treatment, and also severe complication seen in 3.4%. We can also use the uterine artery embolization in combination with dilatation and curettage with methotrexate. And the most is the most numerous treatment modality which was described, and additional treatment was needed in 30% because of treatment failure. The other option of treatment for cesarean scar pregnancy, there are the uterine artery embolization and dilatation and curettage and hysteroscopy, which this option have a high success rate of 95% and a very low complication rate of 1.2%. Laparoscopy also can be no treatment option for cesarean scar pregnancy. The success rate was very high, 97%, and there were no reported severe complication. We can also repeat high intensity focused ultrasound ablation is a novel treatment modality, and none of women require additional treatment or reported severe complication. There are other possibility of treatment, repeated high intensity focused ultrasound with hysteroscopic section curettage, which also a novel modality, a success rate of 100%, and there is no complication. And finally, the needle aspiration and methotrexate with a major complication were present in 13%, and additional treatment was required in 50%. So with this, the systematic review of treatment study published in 2016 in the Fertility and Sterility Journal, this paper concludes this review recommends that treatment option for cesarean scar in clinical practice based on efficacy and safety. And the literature supports an interventional rather than medical approach. And present recommendations are primarily based on case series, and multi-centric, well-designed studies are needed to draw a definite conclusion on how to manage or how to treat cesarean scar pregnancy. This same paper published in 2016, there are 5 approaches for treatment of cesarean scar pregnancy are recommended depending on availability, the severity of patient symptom, and surgical screen. And these options are the resection throat transvaginal approach, the laparoscopy, the uterine artery embolization in combination with dilatation and curettage and hysteroscopy, the uterine artery embolization in combination with dilatation and curettage, and finally the hysteroscopy. This paper recently published on October 2023 in the American Journal of Obstetric and Gynecology, which is a randomized clinical trial comparing hysteroscopic resection versus ultrasound guided dilatation and evacuation for treatment of cesarean scar pregnancy. The study compared two surgical techniques for treating a cesarean scar ectopic pregnancy which is a condition where fertilized egg implanted in the scar from a prior cesarean section. This technique are hysteroscopic resection, which is a minimally invasive surgery that use hysteroscope, a thin lighted tube to see and remove ectopic tissue, and the ultrasound guided dilatation and evacuation, which is a procedure that use ultrasound guidance to stretch the cervix and remove the tissue remove the tissue with surgical instrument. This study found that hysteroscopic resection had a higher success rate than dilatation and evacuation for treating cesarean scar pregnancy. In the hysteroscopic resection group, all 27 women had successfully treatment with no need for further procedure. This suggests that hysteroscopic resection may be a more effective option for the treating cesarean scar pregnancy. However, this was a single center study with relatively small sample size, so more research is needed to confirm this finding. And also, this article published recently in the European Journal on Obstetric and Gynecology about clinical implication of a cesarean scar pregnancy sonographic evaluation and reporting system. This paper concludes that no clinically significant difference were found between groups divided by the new standardized sonographic evaluation and the reporting system for cesarean scar pregnancy in pregnancy characteristics management and subsequent pregnancy outcome, and further investigation is required to enable informed management of cesarean scar pregnancy based on the new sonographic reporting system. And now I will talk about our experience, the Tunisian experience, the experience of our D department. In our department, we have managed 28 cases of cesarean scar pregnancy since 2017. The main age of the patient was 13 years old. The main parity were 1.8, and all women had at least one previous cesarean section. Metrorrhagia and pelvic pain were the two most common symptoms in our series. The main beta SCG level was 13,620, and positive diagnosis of cesarean scar pregnancy was made in 100% of cases by endovaginal ultrasound combined with Doppler. And since 2022, we use the modified Delphi methods, which is the use-yog reporting system for ultrasound terminology. And in our experience in our department, all patients were treated with methotrexate. And there are 16 women received local methotrexate via the endovaginal route, and 12 women received local and systemic methotrexate at the same time. And in our experience, we have reserved the combination of local and systemic methotrexate for pregnancy that are evolutives, that have more than 8 weeks of amenorrhea, or have a beta SCG level above 10,000. The success rate in our series was 96%, and additional treatment was required in 4% of case, like hysteroscopy or dilatation and curettage. And there are no cases of hysterectomy for hemostasis were necessary in our series, and the average time for the beta HCG negativation in our study was estimated at 64 days. And our experience will be published soon, inshallah. Our article is under review. And here there is a video about the local injection of methotrexate. You see the video, Dr. Ritu?
No video is visible, only the picture is visible.
There is a technical problem.
Okay.
So,
No issues.
so thank you very much for your time and your attention. And if there is some question, I am here with you.
Thank you. Thank you so much, Dr. Fathi. A very nice presentation. Will you
Thank you
please
very
stop
much.
sharing the screen? Yeah. So, really a very nice presentation. You covered very nicely all the things.
Thank
Actually, the program is going live on the YouTube also. If I receive some questions, I will definitely share with you. Till now, we are getting only the appraisals. Chitra and Sahiti, will you please show the certificate? This is a certificate of appreciation to you, Dr. Fateh, for being
thank you very much.
as an icon in the program. So thank you once again for sharing your knowledge with us. I
Thank
will
you very
send you
much.
this also. I will send you. Yeah. Friends, if there are any questions, we can take quickly. No, currently there are no questions. Means the presentation is very nice. So thank you. Thank you once again, Dr. Fateh. Thank you, Chitra. Thank you, Sahiti. And thank you, Shield Healthcare, for constantly providing the platform for this program from last 3 years. And thank you all dear friends who have joined all across the geography. With this, we will wind up for today. So thank you. Thank you, everyone. Bye-bye.